Tokyolive,
Endoscopy 1.
So welcome everybody. My name is Rob Hawes, and it's a distinct pleasure for me to be part of Tokyolive. I want to thank Haro Inoue and all of the organizing people for the invitation to be part of this extraordinary meeting. I'm sorry that we can't get together personally, but it's certainly better than nothing to get together by video. It's my pleasure to moderate this session on interventional EUS, and I have the both the honor and the pleasure to be moderating two of really the superstars in interventional EUS, and I look forward to their presentations, and I think all of you will learn from these two presenters. The first presenter will be Michel Kahela. Michel trained originally in Brussels. He then came to the United States and was on faculty at the University of Virginia, where he really established his career in interventional endoscopy, began his career in innovation in endoscopy, and really established Virginia as a hotbed of interventional endoscopy. He then moved to the Big Apple. I think he needed a bigger stage, perhaps, to work, and he joined the Weill Cornell faculty in July of 2011, and continued his stellar career there until 2017. He's now clinical director of gastroenterology and chief of endoscopy at Rutgers Robert Wood Johnson Medical Center, and again has continued in his practice. He has a great passion for new technology and its introduction into clinical practice. And so today we've asked him to present on endoscopic ultrasound-directed transgastric ERCP. The acronym that we use is EDGE, and we want him to present the current status in North America. So Michel, welcome, and great to be with you.
Rob, thank you so much for this introduction. It was a very beautiful one. I don't know if you can see that, but I'm actually blushing right now as we speak. So it's my honor and my pleasure to be part of this fantastic conference. I hope you guys can see my screen. I want to thank the organizer and especially Haro Inoue, who is my mentor in third space endoscopy, to be part of this phenomenal meeting. And I really think the topic is just incredible, and being part of this fantastic faculty is my pleasure and honor, as I said. So I've been asked to talk about EDGE and go over the current status in North America. So we have to remember that the United States is a very specific country where there's a lot of people that are obese. There's 35% of the adult population have a body mass index more than 30 kilograms by millimeter square. The indication for bariatric surgery, as everybody knows, is a BMI more than 40, or sometimes BMI more than 30 when there's comorbidity associated. In the US, the Roux-en-Y gastric bypass is the most commonly performed, as well as the rest of the world, which consists approximately up to 47% of the bariatric surgery performed. In the US, it's actually estimated to be close to 60%. So what are the solutions to access the biliary tree in Roux-en-Y gastric bypass? It is very important to understand that in 2021, there's three options for us. Laparoscopy-assisted ERCP, balloon enteroscopy ERCP, and now EUS-directed transgastric ERCP, or EDGE. EDGE was invented in 2014 while I was still at Weill Cornell, and Prashant Kedia and I, who was at that time still in training, we performed the very first procedure in 2014. What we tried to do at that point is every case that we were doing, we actually capture into a dedicated registry. And this publication published by Amy Tyberg, who's joined us at Rutgers with Johnson, was actually the very first large series establishing EDGE for ERCP or EUS for people that have Roux-en-Y gastric bypass. And as you can see here, with an efficacy of 91% and technical success of 100%, EDGE was born to go further. Initially criticized by many people, all those same people that actually criticized it have now adopted this procedure in their centers. The fear was weight regain, but when they figure out that actually the majority of those people don't, gain weight, they actually lose weight because they're sick. They have, cholangitis, they have chronic choledocholitis, they have chronic pancreatitis. Those are not the people that are going to gain weight. So once they figure that out, they one by one started adopting this procedure. The very first step was actually to compare. We did this with Prashant when he joined Poltanaski in Texas, was actually comparing this to laparoscopic ERCP. And we demonstrated in this very nice comparative study that actually the technique have equal technical success, equal adverse event, EDGE having shorter procedure time and shorter hospital stay. Then the next step was obviously to compare it to enteroscopy, which the group of Hopkins did very nicely here. Head-to-head comparison retrospective between 30 patients undergoing EDGE and 30 patients undergoing enteroscopy-assisted ERCP. Same adverse event. However, EDGE had a higher technical success rate, shorter procedure, and shorter hospital stay. Very nice study by our friend Todd Barron, who decided to focus exclusively on costs and look at the cost of the different procedures that are available to us. And he demonstrated actually EDGE seemed to be the cheapest procedure when it comes to offering ERCP in patients with Roux-en-Y gastric bypass. You can notice here that laparoscopic ERCP was 5 to 6 times more expensive than EDGE. So I'm going to show you a quick video here just to find EDGE for a patient that had recurrent chronic pancreatitis and weight loss. As you know, those patients, you oftentimes need to come back. You need to upsize the stent. You need to get access. You need to dilate. Some of them need ESWL. So the very first step of the procedure is to puncture the excluded stomach under echoendoscopy. Then, after filling that stomach, you can then use the hot axios to literally deploy it, first flange into the excluded stomach, the second flange into the pouch. Next step is to dilate. Once you dilate, you have 2 options. You could come back after 3 weeks, which we did in this case, patient has chronic pancreatitis. There's no emergency. There's no need to do the procedure in one step. Or you can do the whole procedure during the same session. We typically suture the axios to the pouch when we do that. In this case, as I said, it was a chronic disease. We decided to come back after 3 weeks once the anastomose was mature. And you can see here, ERCP really focusing on getting access into the pancreatic duct. You can see the stone pouring out from the pancreatic duct, small stone and protein plugs. We're getting access here across the distal stricture all the way into the tail. We're going to dilate, in this case, with the Sohendra, followed by placing a 7 French stents, which we will upsize. The patient ended up having 2 additional repeat procedure for pancreatic duct revision and upsizing the stent and cleaning the pancreatic duct. And the patient did extremely well. Then finally, once we were done with the last procedure, you can see here there's 2 7 French stents in place. We're going to remove those 2 7 French stents in place, get a nice cholangiogram, confirm that the pancreatic duct is indeed patent, that there's no more obstruction. And then we're going to bring the patient one last time, this time to suture the connection between the excluded stomach and the pouch. First, we're going to remove this. So depending on the size, we can either suture or put an Ovesco. In this case, we decided to do an Ovesco. The size was pretty small, it was a 15 millimeter axios only. So we basically removed the the Ovesco, and after removing the Ovesco, we literally we basically put the Ovesco and then move forward. So when it comes to looking at EDGE, specifically in the United States, I'm going to turn your attention to this meta-analysis published by the group of Doug Adler. Interestingly, the group that he assessed, the 4 major publications that he selected, were actually all from the United States. So that gives us also a pretty good perspective that because there's so much obese in the US and because we're doing so many gastric bypass, the majority of those studies are actually from the United States. So you can see that when we compare the 3 groups, what first comes to our attention is the efficacy of EDGE and laparoscopic-assisted ERCP. It's clear that balloon-assisted ERCP is not a very efficacious procedure. Now, when it comes to a complication, stent migration seems to be the leading complication in EDGE. Luckily, most of those stent migration are actually managed by bridging the stent. So you literally cross a wire into the migrated stent and you place another stent, typically a TTA stent, such as the MI-Tech stent or the Taiwan stent that will basically allow you directly over the scope to bridge this migration. Now, the other thing that is remarkable is there is a certain rate, not negligible, of infection in laparoscopic-assisted ERCP. Anytime you access the peritoneum, you have to accept a small amount of infection, which is not reported but doesn't exist actually in EDGE, since all the complications of EDGE are either stent migration or ERCP-related complication. So really, based on this meta-analysis, we confirm that the technical and clinical success of EDGE is better than balloon ERCP and comparable to those of lap-assisted ERCP. Now, EDGE is not as expensive, is more minimally invasive, can be performed by one endoscopist and in one session if needed. It seems also that EDGE has a similar or better safety profile compared to laparoscopic-assisted ERCP. Now, I want to point your attention to a discussion that we have in one of our advanced endoscopy program meetings. As you know, the program director of the advanced endoscopy program tend to meet typically by Zoom 2 or 3 times a year. And during February 2021, there was an inquiry about who is doing EDGE. About 15 centers, which is less than 30% of the advanced program, are actively performing EDGE in the United States. More than 60%, and that was a shock to me, to be honest, are still performing laparoscopic-assisted ERCP. Only 30%, all comers, are still attempting balloon-assisted ERCP, probably because they want to give it one shot before moving to either an EUS guided procedure or a laparoscopic procedure. What are the reasons of not performing EDGE? Well, there's obviously a surgery reluctancy to the procedure, being weight regain the biggest fear of the surgeon, and that is in 73% of cases. The lack of expertise, they've never done it, doesn't mean that they can't do it. They just never done it. In 20%, and there is still 70% that are unaware of the procedure and the current literature. So based on this, my conclusion is pretty clear. EDGE is a safe and efficacious procedure with benefits seen in both compared to enteroscopy-assisted and lap-assisted ERCP. The limited utilization of this procedure described now in 2014, that's 7 years ago, is related to reluctancy from the surgeon due to weight gain fear, lack of expertise, and unawareness. Education is key to permit the endoscopy of the future to offer this technique during symposium, interest group committee, meeting, and of course, PIG lab. But I emphasize also the pluridisciplinary discussion with surgeons at each institution is crucial. And having recently moved to Rutgers Robert Wood Johnson, the first thing that I did was explaining to them this procedure, and we have stopped doing laparoscopic-assisted ERCP and Roux-en-Y gastric bypass unless the patient needed intervention on the gallbladder at the same time. Thank you so much for your attention.
Fantastic presentation, Michelle. I think we're going to wait until after both talks, and then we will field some questions if that's okay.
Absolutely, absolutely.
Okay, so next it's my pleasure to introduce Chris Tashima, and it really is a pleasure for me to do this. Chris is one of those rising superstars who has prepared himself incredibly well for a long and great career in interventional endoscopy. He graduated from medical school in Toronto and then did his internal medicine residency in Toronto as well. He then went to the University of Alberta to do his GI fellowship and also did a master's degree in clinical epidemiology. So he's one of these young people who is prepared to do very serious research as he's prepared for his endoscopic training. He then went to Rotterdam and to the Erasmus Medical Center in Rotterdam to do 2 years actually of advanced endoscopic training. And as is typical in the Netherlands, for those who are gifted and energetic, he earned his PhD while he was in Rotterdam doing his work. He then went back to the University of Alberta and spent time there until 2010, or in 2010. And then in 2015, the group at St. Michael's was fortunate enough to recruit him to come back to Toronto, where he is practicing now. So Chris, as I said before, is just a wonderful individual, but an incredibly skilled endoscopist and a very serious researcher. So it's a pleasure to have him. We've asked him to talk about drainage of pancreatic fluid collections. What's the current status in North America? So Chris, welcome, my friend. It's great to have you.
Thank you very much, Rob. And it's so great to see you. And, you know, it's a real honor to be on a panel together with you and Michelle. I'm just going to try to get mine going. Okay. So, you know, thank you for that introduction. And as you mentioned, I have the privilege of working at St. Michael's with some wonderful mentors there. And we're fortunate to have a great live endoscopy conference of our own. And it's through that conference that I got to meet Professor Inoue, who's been coming there for a few decades now. And after meeting him there, I got to go back to Showa University Hospital in Tokyo and spend some time with his third space endoscopy. So it's a real honor and privilege to be on this panel with both of you. My topic is not as sexy as Michelle's, but probably one that I think has got wider applicability to all gastroenterologists in practice, because pancreatitis is a very common and serious condition, one that we're all facing in our daily practices on the hospital ward. And we can divide pancreatic fluid collections into both pseudocysts and walled-off necrosis based on the Lancet classification, based on whether they just develop from interstitial or necrotizing pancreatitis and based on the presence of solid debris within them. And the treatment of each is slightly different. We know that patients who develop infection of their necrosis have significant risk of demise with mortality rates that exceed 30%. So this is an important condition. So over the years, the endoscopic approach to the drainage of pancreatic fluid collections has evolved. The more traditional older technique required endoscopic ultrasound, puncture of the collection, then creation of the cystgastrostomy tract using a needle knife or a cystotome, then advancement of multiple wires, and then finally deployment of several plastic pigtail catheters. And we did that for many, many years, and then began to evolve to using fully covered biliary metal stents, which would still need the same techniques to access the collection, but instead of using the plastic pigtail catheters, we deployed this biliary metal stent to hopefully improve drainage, as shown here. More recently, we've had the opportunity to use better stents and first acquired these biflanged, fully covered dumbbell-shaped stents. These did not have a hot introduction system, and so we still had to create the cystgastrostomy tract through conventional means with a cystotome or needle knife. And so there's still multiple steps involved before we could finally deploy that dumbbell stent. But quite clearly, over the past several years, we've had the opportunity of using the Axios stent or a fully covered lumen opposing metal stent and in particular one with the electrocautery catheter at its tip, which has enabled direct cannulation into the collection and in a single step followed immediately by delivery and deployment of the fully covered axial stent. And this has really changed the whole nature of the procedure from something in the past that was a little technically finicky, requiring multiple steps and skill, to now one that is routine and all the fellows are deploying these stents quite routinely. So we know that when we're talking about pure, true pseudocysts, that drainage of the pseudocyst is safe, it's easy, and it's effective, and that there's no reason that these patients need to have surgical drainage. Quite clearly from both randomized controlled trials and meta-analyses that endoscopic drainage is equally efficacious as surgery. Meta-analyses looking at just pseudocysts, so not walled-off necrosis, but pseudocysts, would show that actually plastic stents still perform just as well as the fully covered metal stents. And so in terms of clinical outcome and complication rates, you really can say that the plastic stents do just as well. And the only advantage really for the more expensive metal stents is that they're faster to insert. And so there are significant cost savings that can be obtained when deploying plastic stents. And this might not be as relevant in the United States, but quite clearly in Canada, that's an important consideration. And I know in my European colleagues that is too, and I'm not so sure about in Japan, but quite clearly plastic stents are very cheap and they're effective. When we're considering about walled-off necrosis, though, we know that's a different disease and its treatment is more challenging and it needs a more nuanced approach. And so we advocate, and many groups advocate, a step-up strategy when considering intervening for pancreatic necrosis. We know from historical surgical series that early intervention led to poor outcomes. And therefore, there's been this long-standing mantra to delay intervention as long as possible, and ideally waiting 4 weeks to give opportunity and time for the collection to become encapsulated and walled off. If the patient is sick during this time, we can begin treatment with antibiotics, but ideally we try to delay as long as possible till it's encapsulated. If the patient then is still not doing well and the collection is formed, we can then discuss how to drain it. And typically if it's walled off, we would use an endoscopic transluminal drainage method. But if the patients are sick or unstable or it's not walled off, we'll usually use percutaneous catheter drainage. And then finally, in patients who continue to show signs of sepsis and SIRS that are not improving despite drainage, we only then go on to perform debridement, which can either be done from a minimally invasive surgical approach, such as VARD, which is video-assisted retroperitoneal debridement, or by endoscopic necrosectomy. When we're faced with an infection of an acute necrotic collection, as I was just mentioning, we want to try to delay. And so during this time when these patients are really sick and often in the ICU, we can begin their management by a percutaneous catheter and antibiotics. And in the old Dutch step-up study from New England Journal in 2010, they showed that a third of patients were successfully treated just with the percutaneous catheter and antibiotics. So that is something where we can start with. But in that early phase, if patients are still sick, we can actually go on and use hot axios at the bedside in the ICU, particularly because we don't need to use fluoroscopy when deploying axio stents. And we know from recent data that doing so is safe. There's a recent publication of a series of patients in Germany who had to have axios inserted into infected necrosis, followed by endoscopic debridement within the first 4 weeks before the collections were walled off. And these patients did not suffer worse outcomes. And so it indicated that doing so can be safe and effective, although probably should be reserved for patients who don't respond to the percutaneous catheters. Once we have a collection that's walled off and we're suspicious that it's infected, this is when we want to establish endoscopic drainage. And quite clearly, at least in the North American setting, the lumen-opposing metal stents are the new standard of care. There's a number of reasons why they're the standard of care, not least of which is the ease for successful deployment. As I mentioned, all of our endoscopy fellows can do this reliably and consistently, and it's a fast and effective procedure. But more than that, when patients have infected necrosis, there's a high likelihood that we're going to anticipate they're going to need debridement. And clearly when the axios or fully covered metal stent is in place, it really does ease the ability to get back into that collection for that debridement. And we know from many studies, but this one here recently, which showed that in patients who have endoscopic drainage for pancreas necrosis, that the majority of them undergo endoscopic debridement. So that debridement is going to be very, very likely once you start draining these collections. Despite the fact that these stents are our preferred drainage strategy, the data has actually been relatively equivocal. Clearly, in the early years, there was a number of case series all showing safety and efficacy in non-comparative, non-randomized ways. But when comparative studies have been done, they haven't really borne out a lot of compelling data. It's telling us, and I'm not going to go through each of the studies, but in summaries, in a randomized trial from Dr. Hawes's center, there was no superiority to the fully covered lumen-opposing metal stents compared to plastic. Multiple meta-analyses were done in the early years, and the superiority was not seen in those meta-analyses either. What was observed was increased rates of adverse events, and in particular, higher rates of bleeding complications, particularly if the stents were left in for too long. In Dr. Hawes' study, they did modify their technique to remove the stents at an earlier time, but still the analyses were showing higher rates of complications. And it's only now as more non-comparative retrospective case series accumulate more data and meta-analyses are repeated. So just in this past year, there's finally a meta-analysis that shows that there's a clinical superiority of using LAMs over plastic stents for both clinical success and need for fewer procedures. So I think perhaps that in the early years, there was not enough experience with this. And as we've kind of become more accustomed to doing these things, I believe that the data is going to catch up to our practice, because our practice is to, I think, believe that these are a much superior way of draining these collections, and clearly superior to plastic stents. And if you actually just look at the different debridement techniques, so on the left through the old way where there's plastic stents in place in the tract, and the right that through an axial stent, it's a much more cumbersome and finicky process when the fistula is being held open by pigtails. You have to first remove those pigtails, then we have to do successive dilations. Those dilations always have risk of inducing bleeding, and it takes time to do that. And so it adds a lot of time to the procedure when you're not actually debriding. And then you have to get all those stents back in. Whereas with the lumen-opposing metal stent, the access is much easier. Sometimes there's a bit of debris that's blocking the opening that can be removed, and then you can get in quite quickly and get going with the debridement. So it seems that the debridement is more efficient and potentially more effective when you have that nice access. We still have lots of unanswered questions when we're considering our approach to this field. There's still uncertainty and debate about when we should be debriding these patients. There are many experts who advocate immediate debridement for patients who have infected walled-off necrosis, so that the stent is deployed, dilated, and then same session we begin the debridement, recognizing that there's a high likelihood that that's going to become necessary. And there's other equally renowned individuals who say that we should avoid debridement at all costs, that if patients are failing to improve, we should unblock the stent, we should then put an nasocystic catheter in, then we should then do aggressive irrigation. And so when we pull the trigger to start debriding, I think is still an unanswered question, and we need more data. When we do say that debridement is required, it's still not clear what's the best way to do it. We have all these finicky tools that are designed for other procedures, and we use them to try to get this necrosum out. We use snares, we use grasping forceps, we use ERCP devices. More recently, there's this endorotor device. Unfortunately, we have not yet had access to it in Canada. We're always a step behind. But there's some early data suggesting that this is quite useful at tearing up the necrotic debris, and perhaps Michelle has used it and can tell us a bit about it. We still don't know how long to leave these LAMs in place. As I mentioned, Dr. Hawes' study suggested that if we remove them between week 3 and 4, that we can avoid the bleeding complications. But other studies and other series have shown that they've been able to leave these stents in for a lot longer, so long as we get them out before the collections resolve. So I think that's still an area in flux to determine what we recommend to practitioners for when to remove these stents and when to exchange them for plastic. And regarding plastic stents, do they have a greater role in patients who have a disconnected pancreas duct? When we know the patient is going to need some long-term transluminal drainage, would that be a time to consider to begin with plastic pigtail stents? at our center, when patients have infected necrosis and they have a disconnected pancreas duct, we still are going ahead and using Axios to perform the drainage because we think it's going to be more effective. And we worry about the disconnected pancreas duct later, and we aim to get the metal stent out and the plastic stents in before the collection is completely collapsed. But we don't always time it right. And even last week I had a patient that I thought I was going to get the plastic stents back in, and of course the collection had completely collapsed. So what we do with these patients with a disconnected PD, I think, is still unclear. At St. Michael's, this is our approach. When we are seeing these patients with infected necrosis, and if it's not walled off and they're sick, we get interventional radiology to begin by putting in a percutaneous catheter. We're not worried that it's going to, sometimes people say, well, it's going to make it harder to put the transluminal stent in place. That's not been our experience. We think it makes sense to decompress the collection. And if it does so in a way that makes the subsequent transgastric drainage more difficult, we adopted Shyam's technique of instilling normal saline through the percutaneous catheter to kind of reinflate the collection to allow for the transluminal drainage. So once we've stabilized the patient with the percutaneous catheters, we then go on to use the LAMs for perigastric and periduodenal collections. And then if there's further collections that are more distant from the GI lumen, then we end up putting additional percutaneous drains. And so it's not unusual. We laugh that our patients look like a lobster where they have drains coming out from 6 different spots. When there's a partially disrupted pancreas duct, we will still do ERCP to attempt placement of a pancreas duct stent to see if we can facilitate transpapillary drainage. It's not always successful, but we think it's worth trying. If patients fail to improve or they have clinical deterioration, we are relatively quick to proceed with endoscopic debridement. We feel that it is a useful thing to do, and so we're on that end of the spectrum of being a bit more aggressive with debridement. And we typically do this 1 to 2 times per week until we see adequate improvement. And if we determine that we're not able to get adequate debridement from an endoscopic perspective, then we pull in our surgeons and ask them to do a video-assisted retroperitoneal debridement. And sometimes we actually do a combined procedure where we're going in endoscopically to help direct the VARD. And so I'll show what that looks like here. So here's the Axios stent in place, and the endoscope's going to go through it into the cavity and kind of as far down the cavity as you can until it kind of meets up where the surgeon's coming in from the VARD. You can see that the lights are facing each other, and sometimes they're not able to see the different regions of the cavity when they're further away from the flank. And so we can use the gastroscope to direct the surgeon to use the grasping forceps to get at the bigger pieces in the necrosum. And when there's tough parts that are not coming out, we can then use the snare to help break it up into smaller pieces. And then that allows for those pieces to be grasped with the grasping forceps and removed that way. And so this is kind of an early thing that we've been doing recently, where we go in these cases simultaneously, and they've been relatively effective. And then we put a plastic pigtail in to maintain the connection between the different components of the cavity. So in conclusion, we believe that patients with pancreatic necrosis still need to have a step-up approach of a graduated accentuation of interventions. But when that drainage of walled-off necrosis is mandated, we feel that lumen-opposing metal stents are the new standard of care, at least in the North American environment. Although the early evidence was a little bit weak, I think that evidence is slowly emerging that is increasingly in favor of LAMs. But the best strategy for debridement still remains unclear. Thank you.
Okay, Chris, fantastic presentation. I didn't think you could effectively get through that much data in that percentage of time, but you did a really great job. I think what we'd like to do is just have some questions, and I'm going to start this off, but if you guys want to ask each other questions, please join in, and we just want to have a discussion session here for a little while, and then they'll edit it out if we go over time. So my first question is to Michelle, and my question is, I know that you're enthusiastic about EDGE, but you clearly pointed out that from a surgical standpoint, there's still some drawback. So if I'm at a center where we're pretty good with double balloon, We know now that Fuji has come out with easier to use double balloon scopes with bigger channels, shorter shafts, and at least in our center, our success rate is higher than what is quoted in the literature. If we have double balloon, if we have these scopes and we've got the skills, do you advocate at least a try at double balloon enteroscopy for ERCP in the gastric bypass patients? Or are you so enthusiastic about EDGE that even with those skills there, you still advocate going straight to EDGE?
I think it's never wrong to trial an enteroscopy-assisted ERCP. I don't know about your surgeon, but my surgeon makes extremely long limb. Like their limb is like, it's like going to California. I mean, this is the problem. So if your surgeon are doing like shorter limb and you guys are skilled in single balloon and you want to try it first, absolutely, by all means. I mean, absolutely. My surgeon clearly told me, listen, your enteroscopy is not going to work. You can try if you want, it's not going to work. So it's either laparoscopy assisted or something else. So that's why we started the discussion with them, and we needed them to be on board. And I cannot emphasize how important it is to have the surgeon on board, because if something really goes wrong, you're going to need their help. So it's important to educate them, to make them feel comfortable and come up with compromises. And the best compromise, as I said, is if you have a patient that clearly has a gallbladder disease and a biliary disease, that is a patient that's going to have a gallbladder out regardless. So you can do a lap-assisted ERCP in those patients because it's going to have a laparoscopic cholecystectomy anyway.
And so your surgeons are willing to go forward with the cholecystectomy at the same time as your ERCP?
Yes.
Oh, interesting.
Yes.
Okay.
Yeah, and Rob, that's what we have at St. Michael's in Toronto as well. So, in these patients, we do a lot of double balloon, but for the bariatric Roux-en-Y's, it's just too long, I think, to commit to that with a high likelihood or high possibility of failure. So, if the gallbladder is still in place and the patient's presenting with a stone-related disease, we do lap assisted, and the surgeons take out the gallbladder during the same procedure.
During the same session, okay.
And if the gallbladder's out already, then we do EDGE.
So I assume that both of you guys are the same as we are. Most of the referrals for these are not operated on in our center. So somebody else has done the Roux-en-Y. So therefore, it's not always possible to know the length of the Roux-en-Y. Is it worthwhile really trying to get those surgical records, or are you guys just so down on double balloon that it's just worth going straight to EDGE?
I mean, I'm a little bit biased, obviously. I created this, but you have to also remember what is the procedure you're doing. Like that patient that I presented is a patient with chronic pancreatitis.
Yeah.
You need to do a pancreatic sphincterotomy, dilation, stenting, upsizing the stent. This is not something that is very pleasant to do with single balloon. Even if you get there, it's going to be very tedious. So I think if you have to do like just a little stone or just pop 2 or 3 7 French stents, and you're able to get there, it makes sense to get this documentation, try to read how long is that limb. But the data is clear. Single balloon ERCP is between 60 to 70% efficacious. So that means 30% of the patient at least are not receiving the appropriate biliary decompression. So that's why you have to, put everything into perspective.
So I want to dig a little bit more down now, Michelle, on the fistula standpoint, because I agree with you. I think the double balloon enteroscopy for a complex pancreatic case is much different than a double balloon with a simple stone, et cetera. But if you have to do multiple interventions, you've got to wait 4 weeks before you exchange stent size, or you've got to leave the stent in for a while and then try to get some more stones out, thus leaving the Axios stent in for a longer period of time. Do we know what the factors are for non-fistula closure? And is long-term indwelling axiostent one of those factors that predicts non-closure?
Yeah. So this is a great question. And there is now 6 studies that encompass enough patients to have a clear understanding how many people are regaining weight because of the fistula. Out of those 6 studies, there's only 1 study that had shown some patient regaining weight. And in that study, for sure, some of those centers, that's the study of Kashab, some of those centers were not systematically closing the fistula. So they were removing the axios, okay? And they were just letting it close by a second intention. With the size of the axios becoming bigger and bigger, so we used to use 10, then 15, now 20, I can guarantee you that there are going to be a few people that are not going to close. So my recommendation, okay, is to close that fistula by suturing or by ovescoing. That would be my recommendation. There are a few people.
And do you do that immediately? Just predict that it won't close and do it immediately? Or do you wait and see if it will close?
Okay. No, I do it once I'm done with my therapy in the bile duct or the pancreatic duct. Once I'm done and I know I'm not coming back, I will either suture or I will ovesco. Now, the very few people that recur are typically diabetic people or people that are extremely moribund with poor scarring ability, people on steroid. That is my experience.
Okay. Chris, any comments on EDGE? Anything to add from a Canadian perspective?
Well, fortunately, I don't think we still have obesity, but not quite to the same extent. So it's not as prolific in terms of seeing these patients.
Right.
So, I don't think we're seeing the same numbers. Not clear, not even close. But, it's even more challenging question for us because we don't have any suturing devices in Canada. Okay. So you have to be even that much more cautious about this. And it does involve a real discussion with the patient. And often these patients will exhibit a personal preference that they would rather have laparoscopic surgery. Yeah. So, yeah, it's a little different.
So, Chris, I want to go to you now for just a little bit. And you made some really, really good points. And I think you're exactly right. Despite the data and some of that data coming from our center that suggests that plastic stents are equivalent to the LAMs, I think you're absolutely right. The trend is very, very strongly toward LAMs, despite the enormous cost of these devices and so forth. I think one potential explanation, I think it is purely due to ease. I think I grew up on placing plastic stents. I think the younger generation, as you said before, your fellows now are routinely placing LAMs. It's a fairly easy procedure to do. And I think what's driving it more than data is the ease of placement. And I think in terms of ease of placement, what hasn't been talked about enough is really the hot part of hot axios. And I always thought, Michelle and Chris, you can chime in, but I always thought that Boston Scientific, when they purchased that technology, that the greatest part of the IP was actually the hot part. I thought that other people could mimic the stent itself, but putting the stent together with such an efficient hot system was really what drove this technology. So I think it's the ease of placement of LAMs that's driving this, and it's amazing to me that it's despite the enormous cost. But I think, Chris, the other thing is, and this was pointed out in a recent conference that I was at, I think that when you look at our data, our randomized trial, I think the percentage of people that we did debridement on was lower than some of the subsequent studies that have been published. And I think that the point that I wanted to emphasize from your talk is it's definitely easier to do a debridement if you've got the axial stent in than if you've got a couple plastic stents. And so I just wanted to emphasize those parts of your talk.
Yeah. So, I mean, there's a number of things you've said there. So one, I think the data for a number of years got really all mixed up because enrollment would include true pseudocysts as well as walled-off necrosis. And so it was not a homogeneous population of infected necrosis. And so you're getting all these other collections that are sterile, maybe only 10%, solid debris mix in, compared with someone with 60%. And so it washes out in the end. And so there wasn't the ideal patient selection. So that's one thing. Clearly, EUS changes a lot of things, but and you're right, that hot Axios introduction aspect is a real game changer. Our fellows clamor for an opportunity to do an old school case now because they get to the end of the year and they haven't done one. And so if there's just all this buzz, like, oh, we're going to do an old school drainage, then everyone shows up. But now, no one can be bothered for Axios. Yeah. Again, we're talking about the North American perspective. Yeah. But Canada in a way is a different world than the United States. And so, the vast majority of these patients that we are doing with this disease are having the procedures done without the support of anesthesia. Okay, oh, wow. So we have patients who are potentially sick. The ones who are really sick and are coming up from ICU, sure, they have anesthesia, but then we want to go down to ICU and do a really quick procedure. So the EUS is clinically relevant. Countries like the UK, some different European countries don't have great access to anesthesia. We don't. It's variable across parts of Asia. So now when you're talking about conscious sedation, time actually matters in terms of safety for the patient too. Yeah. That it's not, I think, more than just convenience. Time actually matters for clinical reasons. Yeah. So
the only other thing that I wanted to emphasize, and maybe we go overboard on this, but is this issue of disconnected duct syndrome? Because if you really look at it, in those patients with true pancreatic necrosis, the incidence of disconnected duct syndrome is actually quite high. And so I do want to emphasize that at least at some point, you really do need to get in double pigtail stents. I understand that and it's the same at our center, the tendency to use lambs is really, really there, but we make a strong effort to look for disconnected duct as early as possible and try to avoid that circumstance where that you described. Now, again, in our center, we do believe in our data of bleeding, so we're fairly early in taking out our lambs. But I should emphasize to the audience that with disconnected duct syndrome, you really need to make an effort to know that it's there and then get some double pigtail stents in for the best long-term care of those patients.
Yeah, absolutely agree, Rob. That should always be the goal for those stents to go in.
Okay. Michelle, any comments? We're right at 8:53. We had I think 50 minutes for our session, but any comment? I know you've done a lot of work in this area as well, Michelle. Any pearls of wisdom that you want to contribute on this?
I think two things that, globally, I totally agree with the discussion that we've been having, but two very important points is there is still a place for double pigtail plastic stent. Obviously, you talked about disconnected duct syndrome, obviously, but when you have a simple pseudocyst, there is no reason to use an Axios. And as I said, our fellow are getting spoiled now. They want to pop an Axios into anything. And I'm like, wait a minute, this is a 5 centimeter pseudocyst. It's simple, pop 2 pigtails, just show me you can do a conventional procedure. So that's number one. Number two, we're very, very obsessed about enteral feeding. And I think especially for those poorly organized fluid collection, we always talk about draining and debridement. And absolutely, if there is an indication, just like you pointed out, patients that are sick, patients that have pain, patients that are septic. But if you have a poorly organized fluid collection and the patient is not septic, is not too sick, he's just there with that huge collection, can't eat, he's nauseated, he's vomiting. Those are the patients that in our institution will benefit the most from enteral feeding.
Yeah.
You PEG them, you vent their stomach for the symptom relief, you feed them beyond the ligament of Treitz, and you come back 1 month later and the fluid collection is organized.
Fantastic addition there. We're hugely supportive of enteral nutrition, and I think it's not used enough, and a super good point. Well, listen, I want to thank both of you for really stimulating, excellent presentations and excellent discussions. I wish I could give you a big bear hug if we were in person, thanking you for your presentations, but we'll have to reserve that maybe for next year. But I wish you both the best. Thanks so much for wonderful lectures, and look forward to seeing you guys somewhere on the trail in the near future. And Haru, thank you too so much for including us in this wonderful conference. We appreciate the opportunity to be a part of it. Thank you so much.